You're the man, the myth, and the legend, Dr. Kevin Boyd.
I spent half of my career being totally in the dark about this. I didn't come out of dental school or even my pediatric fellowship knowing this stuff. I call a 9-year-old a geriatric patient now. We're starting them as young 2, 3, and 4. That's where we can make the biggest difference. We know hypoplastic malocclusion, meaning the jaws are too far back and too narrow, that will not self-correct. The connection between orofacial myofunctional disorders and malocclusion etiology, it's 100% connection. I'm so dependent on having a myofunctional therapist to work with me, and I recommend it on every single case. It's helped my results achieve faster, more efficiently, and more stable, less resistant to relapse. There was no malocclusion until about 300 or 400 years ago. And malocclusion enters into the human condition along with artificial foods and ultra-processed foods and antibiotics, and there's all kinds of things that allow malocclusion to persist now. The bones of the jaw, they will not grow to their full potential. Jaws need to be stimulated as they were throughout our hall of human history, through nursing and weaning and breathing clean outdoor air through the nose, chewing, masticatory competence, respiratory competence. Certainly by 2.5 years old, that chin will not come forward. That deep narrow palate is not going to get shallow. That V-shaped arch is not going to become U-shaped. The lack of spacing between the front teeth is not going to self-resolve. It won't. The distal step will always, 100% of the time, develop into a full skeletal class 2 malocclusion if measures are not taken to help those jaws develop to their full transverse potential and then start to guide that lower jaw forward. If you see anterior crowding on the lower jaw in the incisors, 100% that is a proxy for maxillary transverse deficiency. You do not need a dental crossbite to diagnose skeletal transverse deficiency in the maxilla. Okay, end of story. Even if this child is not displaying airway issues, it's a good idea to develop those arches so that the permanent teeth will be more resistant to age-related periodontal disease when they're older. There may be sleep and breathing issues that aren't perceptible yet, but you know what? Get a hold of it. The malocclusion is not going to self-correct. I use all kinds of different functional appliances to help children, help their jaws come forward. There's so many papers that talk about maxillary expansion conferring better quality of life. These are all things that orthodontists don't want to talk about.
Do you think every orthodontic case needs myofunctional therapy?
Absolutely, unequivocally. If there's malocclusion, there's myofunctional disorder. Help parents understand this is in your child's best interest, best long-term health, and not only lifespan, but health span, how long they will stay healthy into older age. Airway health is seen as much a component of what defines oral health. Surviving and thriving, that's what it's all about.